Welcome to AETCM, the Emergency Medicine channel. Today we are discussing a case about 65-year-old male patient, known case of type 2 diabetes COPD, present to a year with fever with cough and breathlessness since last 2 days. Initial assessment, patient was conscious and oriented, was not able to complete a full sentence. In primary survey, airway is patent, there is no pooling of secretions, and there is no hoarseness.
How do you know that airway is patent?
Sir?
When you see a patient in emergency room, how do you know that the patient's airway is patent?
He's talking.
Most important thing is a breathing difficulty patient is talking means mostly his airway is patent.
Air is patent. There is no pooling of secretions. There is no hoarseness or stridor. And breathing, respiratory rate is 32 per minute. Saturation is 80% in room air. Air entry was bilaterally
85%.
80% room air. Air entry was bilaterally equal and bilateral wheeze is present. On inspection, he was opening his mouth and breathing and use of accessory muscles of respiration. On circulation part, heart rate is 105 per minute, BP is 150/100 mm mercury, and all peripheral pulses are palpable. Disability.
What happened to the pulse in COPD? Pulse.
High volume.
High volume. What is the reason for high volume pulse?
Anemia.
Huh?
Polycythemia.
Not because of that. What happened to your blood vessels when you have high carbon dioxide retention?
Vasodilatation.
That is the reason. That's why they get headache, bounding pulse. Okay. So pulse will be normal in all COPD patients. Sometimes it will be warm peripheries, but patient will be still having severe cyanosis, desaturation. Okay. Disability
if GCS E4, V5, M6, peoples are bilaterally equal and reactive. Exposure, there's temperature 100 degree, and GRBS is 190 milligram per deciliter. For temperature, we give an injection PCM 1 gram IV stat. Adjuncts of primary survey, we first taken VBG, there is pH is 7.313, PCO2 68, bicarbonate is 33.5. A patient is respiratory acidosis with a compensated metabolic alkalosis.
Okay. So 7.31.
313.
7.31. 313. 313 and
PCO2 68.
Retention is there.
Bicarbonate 33.5.
Okay. What is the lactate level?
Lactate 1.2, sir.
1.2. Okay. HB percent?
HB 16.6, potassium 4.3, sodium 133.
Okay.
An ECG shows sinus tachycardia. Then we take a USG EFAS chest to look for bilateral lung sliding sign to rule out any pneumothorax. In secondary survey, 62-year-old male patient, known case of type 2 diabetes mellitus and COPD. He was presented with complaining of fever associated with cough with expectoration of white sputum since 2 days. During that time, his breathlessness worsens and he was not able to do his routine activity. His MMRC score, baseline score is grade 1.
Okay.
That's why he came to our hospital for further management. There is no history of chest pain, orthopnea or PND. Then head to examination. There is no pallor, icterus, lymphadenopathy or edema. In upper respiratory tract examination, there is no sinus tenderness.
If the patient is having anemia, what is the most striking diagnosis you can make in a COPD patient? Here it is 16. That is a normal, usual phenomenon. If there is anemia in a COPD patient, smoker, what is the first differential diagnosis you think? You have to always think about malignancy. Normally, you don't get any anemia in a COPD patient. You get always polycythemia. But if you are seeing, even if there is slight amount of anemia, you have to rule out malignancy, especially lung malignancy.
In respiratory system examination, by inspection barrel-shaped chest, there is no supraclavicular hallowing and a usage of intercostal muscles are present. In palpation, inspectory findings are confirmed. Auscultation, the bilateral wheeze is present. In CVS, S1, S2 is good. There is no findings of core pulmonary features like bilateral edema, tender hepatomegaly, raised JUP. And then we take a chest X-ray of the patient. Chest X-ray, there is hyperlucent lung field, tubular heart, diaphragm is pushed down with rib space are widened.
Okay, so what is your diagnosis? Finally, when the patient come to ER, what is your diagnosis?
Patient with acute exacerbation of COPD due to infection background.
So
with
infective exacerbation of COPD. That is a common diagnosis we make. Whereas asthma, it is inflammatory exacerbation. This is infective exacerbation. So how do you manage this case in emergency room? In acute settings and chronically in your ICU, how do you manage?
First of all, by your auscultatory and vitals, first of all, there's VCs present. We nebulize the patient.
What nebulization?
Duolin, salbutamol, and hypertropium.
Hypertropium. Both are different in action. They both have the actions are entirely different. What is the action of salbutamol?
Salbutamol is beta 2 agonist. Hypertropium is anticholinergic.
Okay, so how do they differ in COPD? Where is the problem in COPD?
COPD, small
airways.
Hypertropium bromide is more.
Hypertropium is better than salbutamol, but we give as a combination in most of the diseases. Okay,
then we can give injection hydrocortisone.
How many cycles you have to give nebulization?
3 to 4 cycles.
So minimum 3 cycles, 20 minutes apart you have to give till the patient improves. What are the common side effects of nebulization?
Salbutamol causes palpitation, tachycardia.
What is the most
muscle cramps?
Why muscle cramps?
Due to hypokalemia.
What is the problem of hypokalemia in COPD?
Because of muscle cramps, the chest
muscles cannot.
Respiratory muscles, especially diaphragm. Diaphragm can have weakness. So we have to be very careful when we are giving salbutamol. What type of hypokalemia it is? Shifting of the potassium. Okay. So a nebulization should be given then after nebulization.
After
oxygen. How do you give oxygen? What are the cutoff points?
In this patient, there is indication for NIV.
Oxygen. First tell about oxygen. Then NIV is anyway we have to give.
Oxygen we can place range 88 to 92 saturation.
Okay. You don't want to give more oxygen.
More than because
just want to maintain just above 85%. That is enough. Why it is like?
Because disabled patient hypoxias are dry for respiration, so we can keep up to 88 to 92.
Hypoxia is a dry for all COPD patients. What happens if you give oxygen?
Patient.
If you give oxygen, what will happen?
Carbon dioxide will wash out. Then the
hypoxia will cover correct. Carbon dioxide will wash out.
Respiratory.
Then what happens?
Respiratory depression, drive will lose. The respiratory depression will happen.
What is this drive? Where is this drive controlled?
Centrally controlled.
Medulla.
Okay.
So there chemotrigger centers are there. That will be detecting a normal blood oxygen and normal blood carbon dioxide. Slowly that centers will sleep off or the respiratory rate will come down. Patient will go to respiratory arrest. To avoid that, you have to keep saturation little lower. 85 to 90 is okay. That is enough. Okay. So after that, after giving oxygen, what is next? So you give nebulization, you give oxygen. Next is what? What is next? Oxygen you can give in various methods. You can give nasal prongs, nasal mask, injury mask, BiPAP.
NIV ventilation.
NIV is the best way to give oxygen. Why NIV is indicated here? What are the actions of NIV?
Because the patient PCOT is more than 45 and acidotic in patient pH is less than 7.35. Respiratory is more than 25. So we can give NIV.
How do it help in COPD? NIV or positive pressure ventilation. What is the action of positive pressure ventilation?
The patient is ventilated during inspiration and expiration. The constant pressure is given.
Okay.
So the carbon dioxide can be washed out.
What happens to the collapsed alveoli in the lungs?
Recruitment of the
so many alveoli are already collapsed in our lungs. Many areas are not used. So that part will be actively participating in the breathing this one. That can be added, and on top of that there is bronchospasm here. That collapsed alveolus also can be opened up with NIV. Okay. What are the contraindications for NIV in emergency room? You are treating a patient with COPD. When will you not ventilate a patient with your NIV?
When if diagnosis there is pneumothorax or
Only is pneumothorax. Then
low GCS.
GCS is very important. If the patient is unconscious, you cannot put him on vent.
In facial trauma.
That is COPD. That is in trauma.
Respiratory arrest or cardiac arrest patient.
Any patient loss of consciousness is very much. The most important feature in emergency room is many patients will have severe vomiting.
Aspiration
or something, they can have vomiting. That type of patients, you have to be very careful. Low GCS is anyway it is important because if you keep on NIV, then patient deterioration chances are very high. Okay.
Patient not able to control secretions. That
some patients will be like secretions are one thing. Some patients are not able to tolerate NIV mask. That is also very important. So all these things you have to take care, and you can start on NIV. Then what do you do?
Then after 1 hour, we can calculate there is NIV failure by HEC score.
So you have to see that and see whether patient is improving or deteriorating. If deteriorating, anyway you will have to put him on mechanical ventilation. Why we are worried about mechanical ventilation in COPD patients? We try to avoid, even when HEC score tell you are intubate, but in our country you cannot do like that. What is the reason?
Because intubation is difficulty to wean the patient.
Difficulty to wean, that is a problem. It takes longer time to wean the patient, wean off patient from the ventilator. That's why we try to avoid. Even when we talk about echo score, we have to ventilate the patient. We try to avoid it only because patient weaning will be difficult. What are the other adjuvant therapies you give COPD patients?
We can given some wax.
Wax. Any role for magnesium sulfate?
Magnesium sulfate, bronchodilator also.
Magnesium sulfate can be given. Okay, that is an adjuvant therapy. Okay, how do you keep the patient in ICU? What all things you take care in ICU? So basically, we give nebulization, oxygenation, NIV, magnesium as an adjuvant. All these things will be done in emergency room. Patient will be shifted to ICU. What all things you take care there?
Antibiotics.
Antibiotics. What antibiotics are preferred?
Levofloxacin, gram-negative and gram-positive coverage.
Okay, you give a good coverage for gram-positive and gram-negative. Levofloxacin or moxifloxacin can be tried. Then steroids.
Steroids are given.
Steroids can be given. Then
anti-inflammatory action.
Okay. Then what else?
Physio.
If we are suspecting viral infection, antiviral can be given. Otherwise, what is diet? What is LTOT therapy?
LTOT therapy.
What is like MDA?
Physiotherapy we can give.
What is physiotherapy?
Incentive spirometry physiotherapy.
Spirometry, that is lung physiotherapy should be given. Incentive spirometry can be trained for the patient. Then
long-term oxygen therapy after discharge.
During discharge, we have to advise LTOT, long-term oxygen therapy. What is long-term oxygen therapy?
It is for 2 liter oxygen given by nasal bronch for 16 hours.
Nearly 16 hours. What is the action of that? We are not trying to improve the oxygenation because we know already learned that it is dangerous. What else it can do? It reduces pulmonary hypertension. Prevents pulmonary hypertension. Not reduce. It prevents the endothelial damage, pulmonary hypertension, so that the patient progression to failure will be reduced. Okay. What is the diet you advise for the patient?
Low carbon, high protein diet.
Potassium should be given to the patient. Magnesium should be corrected. Potassium should be corrected. High protein, low carbohydrate diet should be given. Okay. See, core pulmonary, how do you manage? If the patient is having core pulmonary. Core pulmonary. Sildenafil is used in primary pulmonary hypertension. Primary, not in secondary pulmonary hypertension like this. It may not be helpful at all. Sildenafil is that can be used in primary pulmonary hypertension, not here. Okay. How do you manage core pulmonary? What is core pulmonary? Failure of the right ventricle. What is the problem there? Volume accumulation. So you have to give fluid, not fluid restriction. You give Lasix. Normally we don't restrict fluid in RV failure. We restrict fluid only in LV failure. Suppose you restrict fluid in RV failure, what will happen?
low fluid into the right,
So
right to left.
again the pumping can be reduced because RV to LV flow will come down. Here only if the symptomatic treatment can be given more fluid in the RV with the failure features, you can give small dose of Lasix or Lacilactone. We will not be giving like LV failure, because if you give lot of fluid reduction can reduce the input to the LV, and that itself can be dangerous. Okay. These are the basic things you do in emergency room and in your ICU. What happened to the patient finally?
Finally, got better and discharged.
Discharge. On discharge, what do you advise for this patient?
One is lung physiotherapy
Okay.
can advise, and diet control one, and vaccines can give
Vaccines. So vaccines should be given. H influenza and
one, and
pneumococcal.
pneumococcal vaccines are given.
MDIs you have to give.
Metered inhaler is given.
Metered dose inhalers should be given. Or if the patient is not able to take metered dose inhaler, you can even give nebulization. What you are giving.
LTOT and
Nebulization. Nebulization can be, both are having same effect. What are the common drugs you give in MDIs?
formoterol
With
budesonide.
budesonide. Then you also have to give a long-acting anticholinergic like tiotropium bromide. That also can be given as inhalers. Vaccine should be given for all patients. Okay. Patient is discharged. Okay. Thank you.
Thank you, sir.